I am Dr. Abharajit Ray, one of the senior rheumatologists of Calcutta, attached to Bellevue, Woodlands and Fortis hospitals. And you are seeing me in my own chamber called Radiant Medical Center. Now I have been asked to speak on a topic called rheumatoid arthritis, the foremost inflammatory polyarthritis commonly affecting young ladies between the age of 15 to 45, though it does affect men also. In India, we get a second spike after the age of 60, where men and women are equally affected. Then we come down to the signs and symptoms. A young lady who can't make a fist in the morning, can't get down from bed because of painful sole and feet, extreme tiredness, extreme fatigue, along with sometimes you might get a low-grade fever. And this distribution of the joint pain is symmetrical usually. Both sides of the hands, feet, wrists, elbows, usually the small joints are more affected. The neck can be affected, so cervical pain can be a part of it. But please do remember that lower back is not affected in rheumatoid arthritis. The other important thing is we will go into the investigations. You can have significant anemia, normocytic, normochromic, which does not get corrected with iron therapy or with vitamin B12 or with folic acid. But it improves once the disease is corrected. We also will come across sometimes what is called 70% case rheumatoid factor positivity. The other antibody, which is anti-CCP, which is also positive in roughly 75 to 80% case, two together will make about 85% of the patients positive for rheumatoid factor or CCP. So it does mean that there are about 15% of patients who are clinically rheumatoid arthritis but who are negative for both rheumatoid factor and anti-CCP. The important thing to realize, they will have a raised ESR or CRP and both, which we call acute phase reactance. Regarding imaging, X-rays are early stages, they are rather poor investigations because it only comes out when their joints are significantly damaged after several years. So early diagnosis depends on, whenever does, an ultrasound power Doppler of the swollen hands and feet or the affected joint, which shows synovitis. It is cheaper, it is more economical, and the patient doesn't have to enter any big machine. So hence it should be more and more available. The other thing is an MRI in the early stage, which can show joint swelling, erosions, bone edema and other things suggestive of active inflammation. Then we come down to the treatment of it. There are something which you cannot change, which is the family history. There is a strong family history of rheumatoid in the family. But we can change something like avoidance of smoking, avoidance of tobacco. We have to have a good dental hygiene or gum hygiene, which is imperative. You have to avoid abrupt exposures to high and low temperatures. Stress can bring it on. So we have to be careful how we manage stress, which is a part of normal life. Now the drugs will be mainly three forms. One is the NSAIDs or the non-steroidal anti-inflammatory drugs, which we commonly call painkillers. We have to keep in mind they are damaging for the diabetic patients, and some people can get gastritis and stomachache with them, but they should be used judiciously. Better is to use paracetamol, which is comparatively harmless. Next we come to the actual drugs, the conventional disease modifying agents. The gold standard is methotrexate, once weekly or twice weekly, total dose not exceeding 30 milligrams in India. So there methotrexate acts as an immunomodulator, not as an immunosuppressant. So that's very important. Suppose methotrexate fails, then we add along with it sulfasalazine and hydroxychloroquine. And in ladies who have completed their family, we can add leflunomide. Now suppose these drugs judiciously used will be helpful in 80 to 85% of patients. We can use steroids into the joints local. High dose steroids is better not taken. Low dose steroid can be taken for a short period of time and they can be tapered by the specialist. The next group of drugs will be biologics, wonderful drugs in the millennium. They have neutralized the inflammatory chemicals called cytokines and chemokines produced in these diseases, and they are pretty good gunshots, as it were, for the disease, and we have a whole range of them which we can use depending on the scenario. But suppose still then some of them will be failing on biologics or they can't afford biologics, then we can go down to what is called disease modifying drugs, targeted synthetic drugs like tofacitinib. Fortunately, we have a lot of generic brands which has come into the market and which has pulled the price down. So it's less than 2,000 rupees per month, expensive but much less than a biologic, and they don't require cold chain. They can be had as tablets, so the specialist can use along with conventional drugs like methotrexate in stopping the progression of the disease. Now let me tell you very clearly, if you come with the first 2 years, then there is every likelihood that the rheumatologist will put your disease into remission, which is the best possible thing. But if you come later, after 5, 6, 8, 10 years, then they can be put into what is called a low disease activity. The disease will progress, but at a much slower pace, and she or she will maintain some quality of life. So please do remember, don't become hopeless. You will be your heart, lungs and bone problems, including osteoporosis, will be treated along with the main disease by the specialist, or if he feels, he can always refer you to his competent colleagues of different streams and we can take it from there. So there's a lot of things to hope for, lot of future to hope for all of us, and thank you very much for the patient listening.